Good afternoon. This is part 2 of the Neuroanatomy series from Cameroon, arranged by Ulrich Sydney and other medical students of Cameroon. We're glad to meet them. Nathalie is going to talk about the occiput. We just had a great presentation from Victor Hugo Perez. Let's meet our guests before we turn it over to Nathalie. Hello, Marco.
Hi, guys. Nice to meet you again. For who don't know, I'm Marco Meloni. I'm a consultant neurosurgeon in the North Italy, close to Como.
Welcome, Marco.
Yeah.
Marco. Okay, go ahead.
I was in Congress of Mans last year in Naples.
Where?
Naples. Do you attend of Mans Congress? Naples last year, June. In Naples.
That was IPES conference, right?
I asked you if you was in Mans Congress last year in at Naples.
Oh,
okay. Well, we can talk. We can network after introductions. Okay. Okay. Okay, Ulrich, can you please introduce yourself?
Yeah. Hello, everyone. I'm Ulrich Sydney, final year medical student and research associate at Harvard starting July this year. Nice to meet you all.
Very good, Ulrich. And Nuru, could you please introduce yourself?
Yes, I'm Nuru. I'm come from Benin, but now I am in Morocco, and I am in my third year's residency course in neurosurgery in the Rabat Center WFNS reference center of training of young neurosurgeons in Africa.
You're going to Nepal for his residency. That's great news.
Yeah.
Okay, I don't know if I got Dylan. Hello, can you please introduce yourself? Let me unmute you there, Dylan. Can you unmute there?
Yes, we are here.
Go ahead, Dylan.
I'm Dylan, 7th-year medical student from Cameroon. Nice to meet you.
Welcome, Dylan. And G-Flex2, I don't know if you're there. Could you please introduce yourself? G-Flex2. If not, okay. Nathalie, we'll turn it over to you and welcome. Thank you.
You're welcome.
Go ahead, Nathalie. I'll unmute you there. Go ahead.
Yeah. Just give Nathalie give her 5 minutes, please. There's an issue with the connection right now.
No problem. Okay, let me see. So Nuru, when do you plan on going to Nepal?
Maybe next month in July. I don't know yet, but I will let you know when I.
Are you going for a fellowship, like 3 months or 6 months?
Yes. I think that is 3 months or 6 months, like that.
Okay, because there are about 6 people. There were 6 people at one time. Fellows.
It is in Department of Lippe Sherian about school base.
Yeah. There's another African resident there, I think, from Tanzania, I believe. He's there now.
Good.
And, but yeah, IPE's a good person to know for that kind of stuff. He knows a lot of people, and because when I went there last year, there was no program, no fellows. He was just starting with Dr. Yuha Hernasnemi was there, and they were just starting off, but he's grown pretty quickly to have 6 fellows already. Any luck, Nathalie? I'm going to let you in here again, okay? Yeah, Nathalie's coming in, and she'll be starting shortly. There you go. Okay, Nathalie, you want to give it a shot?
Hello?
Yeah, go ahead, Nathalie.
Hello.
Okay, I'm Nathalie Christelle. I'm a general practitioner in Cameroon, and today I want to present on the occipital bone.
Okay.
And its surgical importance.
Very good.
I don't know if everybody can get me.
We can get you. It's okay.
It looks good.
Please, a minute.
There we go.
Like I was saying, I'll present on the occipital bone and surgical importance. Our main objectives were to have a global knowledge on the anatomy of the occipital bone and its neurosurgical and clinical value as well. In order to achieve our objectives, we have the following plan. After a brief introduction, we shall recall a little on the embryology. We shall go into detail in the anatomy. We shall give some surgical values, and then we shall conclude. As an introduction, we'll say that the occipital bone is a trapezoid-shaped flat bone, unpaired flat bone, which is situated at the back on the lower part of the cranium. It is pierced by the foramen magnum through which it communicates with the cranial, the cranial cavity communicates with the vertebral parts. It is made up of three portions. We have the squama, the basilar parts, and we have the two lateral parts. It has four borders, two superolateral, two inferior, four angles, two superior, inferior, and two lateral. To talk about its embryology, we'll say that in early ontogeny, the occipital bone begins to form from 5 bones. We have a central part, which is the basioccipital. I don't know if everybody is seeing with my cursor. The basioccipital, which is just in front of the foramen magnum. We have the two lateral parts, which are the occipitals, where the occipital condyles are found. We also have two in the flat back, which forms the squama. We have to note that the occipital bone is an ontogenetically mixed bone that is made up of cartilaginous part and a membranous part. The cartilaginous part are the anterior parts, which is made up of the exoccipitals and the basioccipitals, while the membranous part is mainly made up of the squama, which you can see with my my cursor. Talking about the anatomy, we'll start with the squamous occipitalis, the first part. It is a curved, it is situated behind the foramen magnum. It is curved and expanded plate just behind the foramen magnum. It is quadrilateral in shape. It articulates with 6 bones. We have the temporals, the 2 temporals, the sphenoid, the 2 occipitals, and the atlas downwards. It has an equally 2 surface, an external or exocranial surface, and an internal or intracranial surface. The external surface of the, let me stop the video, my video is a little bit poor. I'll just stop the video to be more, okay. The extracranial or external surface is a curved surface which presents midway between the submit and the foramen magnum a crest, a protuberance called the external occipital protuberance. It is made up of 4 nuchal lines which extends from the nuchal plane, the occipital plane up to the nuchal plane down. We have the highest nuchal line, which gives insertion attachment to the gallia aponeurotica. We have the superior nuchal line, which gives attachment to 4 muscles. We have the occipitalis, the trapezoids, we have the sternocleidomastoid, and we have the splenosus capitis. Above this line, the highest nuchal line and the superior nuchal line, we have the occipital plane. We have the occipital plane, and just under these 2, we have the nuchal plane. There is a medial nuchal line which descends from the external occipital protuberance to the foramen magnum. It gives insertion to the ligament nuclei. It gives insertion to the ligament nuclei. Running midline between the middle nuchal line and the and the nuchal plane is the inferior nuchal line. The inferior nuchal line gives insertion to two major muscles, which are the rectus capitis posterioris major and minor. All these muscles are muscles which permit the movements of the neck in all its axis. Then we have the internal surface. The internal surface is divided into four great fossa by the cruciate eminence. We can see the cruciate eminence. It has the form of a cross. We have two upper fossas which are triangular and which lodges the occipital lobes, and two lower fossas which are quadrilateral, which lodges the cerebral hemispheres. We also have at the center the internal occipital protuberance. The upper division of this internal occipital protuberance runs running to the superior angle, which we can see here. Sorry, which we can see here. On his right side is the sagittal sulcus. In this sagittal sulcus, the hind part of this sagittal sulcus lodges the hind part of the superior sagittal sinus, and where this superior sagittal sinus also gives insertion to the falx cerebri. The lower division of the internal occipital crest, which bifurcates at the foramen magnum, we can see down here, near the foramen magnum, gives attachment to the falx cerebelli, which also gives attachment itself to the occipital sinuses. We'll see it further. Its upper part is made of the vermian fossa, which lodges the vermis of the cerebellum. On either side of the internal occipital protuberance is the transverse growth, which lodges the transverse sinuses and extends from the internal occipital protuberance to the lateral angles. You can see it. This part gives attachment to the tentorium cerebelli. There is a confluence between the superior sagittal sinus and the transverse sinus. This confluence gives this groove where we can meet what they call, this confluence forms the torcular, or the confluence of sinuses, as they call. Secondly, we have the lateral parts. The lateral parts are found on either sides. On either side of the foramen magnum, sorry, we can see it here. And on either side, you can also, the lateral part is mainly made up of the occipital condyles. The occipital condyles permits the articulations between the occipital bone and the superior facet of the atlas. It is oval in shape with two extremities. We have an anterior extremity and a posterior extremity, to which is attached the atlanto-occipital articulation. And medially to it, we have a tubercle, which gives insertion to the alar ligaments. At the base of the occipital condyle, we have the hypoglossal canal, which gives passage to the 12th nerve, penile nerve, and the meningeal branch of the ascending pharyngeal artery. Beside each occipital condyle, are condyloid fossas, which receive parts of the occipital condyles, which receive parts of the superior facet of C1 during hyperextension of the neck. At the base of the occipital condyle is the condyloid canal. This condyloid canal gives passage to emissary veins coming from the transverse sinus. Laterally, we have the jugular process. You can see. Laterally, we have the jugular process, which gives insertions to the rectus capitis lateralis and the ligament, the atlanto-occipital ligament. From the This surface is the paramastoid surface, which articulates with the transverse process of C1. At its upper surface is the jugular tubercle, you can see here. This jugular tubercle has a groove where the 9th, the 10th, and the 11th nerves, cranial nerves, cross to go to the extracranial part of the brain. The third part is the basilar part. The basilar part is directed forward and upward from the foramen magnum. It articulates in front with the sphenoid bone and form what's called the clivus. At the inferior surface, we have the pharyngeal tubercles, which gives insertions to the superior pharyngeal constrictor muscle and the pharyngeal raphe. Its upper surface represents a shallow groove, you can see here. Presents a shallow groove which supports the medulla oblongata. Here is the shallow groove, which supports the medulla oblongata and gives attachment to the membrana tectoria. Laterally, we have the inferior petrosal, the groove which receives the inferior petrosal surfaces. I think this sinuses, sorry. The occipital bone has mainly 4 angles. We have a superior angle, which we see here, which articulates with the angles, the occipital angles of the parietal bones, this in red. We have 2 lateral angles at the extremes of the transverse sinus, which receive the interval of the mastoid parts of both the parietal and the temporal bone. You can see up and down. And then we have an inferior angle, which fuses with the body of the sphenoid anteriorly. We have also 4 borders. 4 borders. We have a 2 superolateral borders, which forms the lambdoid suture. It articulates with the parietal bones. We have inferior-lateral borders, which forms the occipitomastoid sutures, which articulates with the mastoid process of the temporal bones. And we have the petro-occipital sutures, which articulates with the petrous part of the temporal bone. We also have the spheno-occipital sutures, which fuses with during adolescence around when it reaches 22 to 25 years old. Now, talking about the surgical value, we say that one of the most important steps in posterior cranium opening is localizing dural venous sinuses. As seen before, we see that the posterior fossa is made up of 4 to 5 main venous sinuses, amongst which we have the transverse sinuses, we have the superior sagittal sinuses, we have the occipital sinuses, or the inferior petrosal sinuses. We can see some of them here. We have the transverse sinus, we have the sigmoid sinus, we have the occipital sinus, and we have the inferior occipital sinus, petrosal sinuses. Intraoperative damages of these sinuses may result in profuse bleeding and later thrombosis, venous outflow disturbance, or increase in intracranial pressure. We have 3 main neurosurgical approaches of the occipital, of the posterior fossa. We have the suboccipital, midline suboccipital approach. We have the lateral suboccipital approach, and we have also the retromastoid approach. I don't know if everybody can see. The main positions used during a surgery of the posterior fossa are the sitting position. You can see it on the first diagram. We have the park bench position, and we have the prone position. The most used from my findings are the park bench position and the sitting position. We will start with the midline suboccipital approach. The midline suboccipital approach permits us to have a larger view of the posterior fossa up to the craniocervical junctions. As you can see, we have all the structures which can be seen when opening through this approach. How is it done? We do a median incision 2 centimeters above the inion. The inion is the most scient part of the occipital bone, most protruding part of the occipital bone, to the spine process of C4, as you can see. The craniotomy is done with a high-speed drill from the transverse sinuses, that's the repair from the transverse sinuses to the foramen magnum, and takes also part of the posterior arc of C1. While doing this procedure, we must be careful so not to injure the atlantoidal-occipital portion of the vertebral arteries, which enters just laterally. Secondly, you have the far lateral suboccipital approach. The far lateral suboccipital approach is mainly used when we have an injury or a lesion of the hemispheres of the cerebellum. The first image, the first diagram illustrates the incision. The incision goes from the tip of the ipsilateral mastoid. It continues above the superior nuchal lines. It's above the superior nuchal lines, and then descends medially up to C3. Be careful with this, with the far lateral suboccipital approach and the retromastoid approach. We have some landmarks, and one of the landmarks is the asterion. The asterion is that portion where the occipitalis, the temporalis, and the temporalis and the parietal bone meet. That's what's called the asterion. And the asterion has been there have been described many techniques on how to repair or to how to find how to give landmarks, bone landmarks, or muscle landmarks, or muscle, or using muscles to look or find these landmarks, particularly the asterion, because the asterion is the part which is most next to the transverse sinus. We also have the retromastoid approach. The retromastoid approach is mostly used when you have the cerebellopontine angle meningiomas, for example. And in this approach, we have different incisions can be made. We have the linear incision, we have the curved incision, and we have the curvilinear incision, as you can see. This is a curved incision. A linear incision can be made, a curved incision as here, and a curvilinear incision. We have to know that when we do a linear incision, it gives us less. It gives us less space. It gives us less space to do our craniotomy. So it's usually used when we want to use an endoscopy for the surgery. This article was written by Dr. Kivilev and collaborators in 2016. He used muscle insertion line as a simple landmark to identify the transverse sinus when neural navigation is unavailable. I think this is an important article for particularly also in low and middle income countries where we don't usually have these neural navigation techniques. This article was, he used the insertion of muscles such as the rectus capitis posterior majoris and minoris. And he realized that with he did MRI on most of the patients, about 66 patients who were supposed to be operated with having posterior lesions. He used MRI and used T1 and T2, the T1 and T2, where he realized that the insertion of these muscles were about 1.4 centimeters under the transverse sinus, as you can see. On the 56 patients that on whom he made the study, realized that the incision of these muscles were just 1 to 2 centimeters under the transverse sinus. Meaning that if you want to do, for example, a craniectomy, if you do it just under the insertion, at the level of the insertion of these muscles, we have less risk to injure the transverse sinus and then cause complications. So to conclude, I will say that the occipital bone has important landmarks for surgical procedures of the posterior fossa and the craniocervical junction. Skull opening in the occipital and suboccipital regions might be associated with the risk of damage of the transverse venous sinus and the confluence of sinuses, also called torculum. So a good knowledge of its anatomy renders neurosurgical approach easier and less risky. Thank you. Are you sure that you're ready?
Yes.
Great. Okay, I'm sorry, I had some confusion. Thank you very much, Nathalie, for putting that together and taking the time. Can we have some comments or questions from any of the panelists?
I'd like to make a comment.
Go ahead.
Okay, so I would just like to say it was really great. What I really very much appreciated was the detailed description of the surgical importance of the hospital, especially the article at the end where she highlighted a really important part for we who are in LMICs, like for the approaches for the posterior fossa and then the technique based on the muscle insertion was really very great.
Did you get that, Nathalie? Was that a comment or just a question?
Thank you.
Yeah,
Thank you.
just a comment.
Okay. 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 Very good. Now, this is a question, I don't know if it's related. What animals are similar to human brains to simulate dissections? Is there any, like rats or rabbits? Is there any species, Marco, that rather than getting a human brain, you can kind of dissect similar anatomy in an animal? Are there any animals similar that neurosurgeons use if they can't get to a cadaver?
Well, actually, in my experience, I saw the use of a sheep brain in some course, in particular in pediatric neurosurgery.
Okay.
Quite similar.
Similar anatomy, pretty similar.
Yeah. And in my own experience, I joined a course about the use of flocil, is an hemostatic material, and we use some big pig under general anesthesia to perform laminectomy in a spine, and they use the flocil.
Similar anatomy, right?
Yeah, and obviously we cannot forget the use of the rats in the vascular anastomosis. It's very important.
Okay, and the use of, what's that again, Marco? The use of what?
Yeah, it's not about brain, but in neurosurgery practice, the use of rats, mouse, to
grafts, like vein grafts and.
Yeah, exactly. Vein graft, anastomosis to perform bypass is very good training using this animal.
Oh, okay. Now, have the students done any labs like that where you're sewing and doing anastomosis? Are we doing that yet, or that comes with more training? Nathalie or Ulrich or Dylan, have you guys done any of that at all? No. Okay. Okay, that's something that'll come later, I'm sure.
And I want to take advantage, John, to thanks Nathalie for your presentation. It's also very beautiful, and I appreciate a lot the aspect, the surgical practice in occipital bone, the surgical.
Yeah, we have two panelists that are going to Nepal, Naru and most likely Nathalie.
Oh, obviously, thanks to
yeah, I was turning into a real training ground for Africa there.
I would like to thank Nathalie for his great presentation, and thank you, and it is awesome, and I hope it is very important to know about anatomy of bones of all the region, like occipital, because we know that the lobe, the occipital lobe, if you want to remove fossa cerebral posterior tumor, like you have to know correctly the anatomy to done your approach. So it is very, very important to know because anatomy, it is like the way. So if you don't know the way, you can't operate. So it is important to learn more and read everyday anatomy. It is so complicated. So thank you for your presentation.
Thank you, Nur.
Yeah, it's a lifelong study, right? A career of a neurosurgeon, lifelong. And you know, Naru, Nathalie will be able to use this video as part of her resume, her video resume, because it'll really be proof that she was at a conference, she gave a presentation, a very good presentation, and included in the panel were a couple of neurosurgeons, residents, one from Italy. I mean, this is great in her resume. It'll look really good. And I think that people, rather than having paper resumes, they'll have video resumes where prospective employers can easily check, So, okay, very good. Thanks everybody for coming. Thanks, Nathalie. We'll talk later after this, and thank Ulrich and
thank you very much.
I'm going to stay here. We'll just sign off officially, okay? Okay, we'll see you next week.
Okay, thank you.